I thought was I'm going to be talking inshallah next week on diabetes as well. So I thought I'm going to divide my talk on diabetes in such a way that I shall be talking about very simple and basic concepts about diabetes. In the first talk today, I shall be talking about what diabetes actually is, and in the next talk, that is inshallah next Wednesday, I shall be talking about how do we treat diabetes. I was just talking to Dr. Nasir. There are certain recommendations which have been given by different authorities about what to do in certain clinical setups, like in heart failure or in kidney failure or in hypertension. But Dr. Nasir has just mentioned it to me that for all practical purposes I should not be discussing those recommendations. I feel those recommendations sometimes could be very controversial, and on the whole, for a group of family physicians, I wouldn't be very keen to pick up controversial grounds. I want to give very clear, accepted and consensus statements rather than recommendations on these points. So with this, I'll start on with the first part. What is diabetes? I mean, it's a very common problem, but when we start thinking about it, it is associated by two factors. Number one is a chronic hyperglycemia, and this hyperglycemia primarily is either due to an absolute or a relative lack of insulin. The word absolute is easy for us to understand because there is no insulin, so the person is going to be diabetic. It is sometimes important to keep in mind that there could be a relative lack of insulin. Relative lack means that the amount of insulin in the body is optimized, is adequate, but the efficacy of that insulin probably is not there. So insulin is not being produced by the pancreas, which I have just mentioned is an absolute lack of insulin, insufficient insulin, or we may have a resistance to insulin. So the definition basically is a hyperglycemia which could be due to an absolute or a relative lack of insulin. Now insulin helps us to mobilize the glucose into the cells. And when the glucose goes into the cells, it's just like a fuel or a petrol for that particular cell. So if it's not going in, the cell consequently is not going to be functioning properly, and at the same time there will be some sort of effects which are going to occur if that glucose remains in the blood for a higher level. We have got a few main organs that we need to keep in mind. Number one is muscles, then we have the fat cells, then comes the kidney, and finally the brain. So all these organs are going to be functioning when insulin is going to push this glucose molecule into the cells for the metabolization. I felt that it is important to keep in mind why diabetes is important. Diabetes is important because it is increasing. The effects of diabetes are disastrous as the time is going to go by. The WHO has given in its report, which was published in Diabetes Care in 2005, said that it's the 5th leading cause of death globally. So the global perspective of this disease is definitely there, that it's not only on the rise in our part of the world, it is on the rise in every part of the world. The global mortality attributable to diabetes in year 2000, that is about 6 years ago, was 2.9 million deaths. Now this figure is going to rise in an alarming proportion as a couple of decades are going to go by. The excess mortality was accounted for 2 to 3% of deaths in the poorest country and over 8% in the countries which have got affluent sort of population. Between the ages of 35 to 64, 27% of the deaths were attributable to diabetes. So in a nutshell, this disease is not only on the rise, but the mortality which is associated with this disease is also increasing in a global proportion. Now, there are many statistics which have been published by various consultants and various institutions in Pakistan. I felt rather than going on for those data, I should get the data which was given by the WHO survey, who did the glucose tolerance test all over in different parts of Pakistan from 1994 till 1998. So with the glucose tolerance test, they found that the impaired glucose tolerance test in different parts of Pakistan was also significantly alarming. The overall percentage, which has not come up very clearly, is something around 11.4% all over Pakistan. And Punjab, especially the urban Punjab, we are talking about 13% of people have impaired glucose tolerance in the cities. In rural areas, it is significantly low. Probably the lifestyle in the rural area has got a lot to do with the decrease in the percentage proportionate to what we see with the statistics of overall Pakistan. In Sindh, it is 13.9 in rural area, 16.5 in urban area. In Baluchistan, it is 7.5 in the rural area, 10.8 in the urban area. Northwest NWFP, they only looked at one area, and that is the rural part, which is 12%. So on the whole, if we see 11.4% of people in this part of the world, in this country per se, have an impaired glucose tolerance test, and this is given in their annual report submitted by WHO. The size of this problem is, as I was mentioning, that it is increasing. The number of deaths attributed to diabetes was 800,000. But this has been a figure which, as a matter of fact, much less than what the actual plausible figure is. It is going to be around 4 million deaths related to this disease in about couple of decades from now onwards. Coming down to what are the different types of diabetes. Generally speaking, we are going to divide this condition into two main types: primary and secondary. The secondary means that there is something which is occurring over the period of time which is producing this disease, and the primary is divided into two main parts: type 1 diabetes, which is the insulin-dependent diabetes, and type 2 diabetes, which is the non-insulin dependent diabetes. The secondary causes of diabetes could either be related to pancreatic disease or could be related to what we call insulin antagonists. It's again the same thing that we are coming back to. Either there is a insufficient insulin which is there, or the insulin has become ineffective, or the function is compromised. So the pancreatic disease which can produce these problems could very well be pancreatitis, pancreatectomy. If they remove the pancreas, there isn't any place for insulin to be synthesized. Hemochromatosis, where the iron deposits not only go into liver, but it also go into pancreas as well. Or finally, if we are dealing with some sort of tumors which destroy the pancreatic cells, we can have a pancreatic deficiency producing secondary form of diabetes. Now, the insulin antagonists are basically related to what we call counter-regulatory hormones. Now, counter-regulatory hormones are those kind of hormones which have an action opposite to what the action of insulin is. Now, looking at it, they are the growth hormone, and certainly if the person has acromegaly, where there is an excess of growth hormone, the person is liable to develop some sort of glucose intolerance. Corticosteroids, and the example of corticosteroid excess is Cushing's syndrome, and certainly the person can have diabetes or impaired glucose tolerance in that setup. Thyroid disease, particularly hyperthyroidism, catecholamines, and the disease which can produce an excess of catecholamines is pheochromocytoma, and you can see glucose impairment quite early in the disease of pheochromocytoma. Then pregnancy, it actually produces a very different type of diabetes, and as I'm going to be talking a little bit later on, we have actually defined and designed a special category for this situation, and we call this as gestational diabetes. And in pregnancy, it is the placental lactogen which is the main hormone producing this problem. Glucagon problem, which is present in the pancreas again, can be a counter-regulatory hormone to insulin, and glucagonoma is the disease which can produce that. And finally, on the whole, we have an upsurge of all these counter-regulatory hormones, and this is one of the examples that we see when the person has a very significant degree of burns. The drugs which are commonly associated with problems related to diabetes are thiazide, corticosteroids, phenytoin. These are just the three examples of the drugs that I have mentioned. There are scores of drugs which can produce problems with insulin and can subsequently lead to diabetes. Now, talking about genetic syndrome, it is very important for us to understand that genes play a vital role in both insulin-dependent diabetes as well as in non-insulin-dependent diabetes. And the genetic control can produce certain problems, and one of them is what we call DIDMON. As a matter of fact, this stands for diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. It's a constellation of these diseases which constitute DIDMON. Then we can have a problem with chromosome 4, and with the result there is a mutation, and the person can develop diabetes as a result. Finally, the insulin which is being produced has to be a very specifically organized collection of amino acids. If one of the amino acid is changed or replaced, the whole effectiveness of this insulin molecule can be jeopardized. So insulinopathies are conditions where the insulin is not the kind of insulin that we expect to be produced by the pancreas. There is some sort of variation in the amino acids we can anticipate, and that insulin is of a different type. Now this brings me to a very, very significant juncture, and that question that I have to ask is type 1 and type 2 diabetes are the same form of diseases? We call them diabetes, but strictly speaking, they are two different kind of diseases. They have got very different sort of origin, presentation, and outcomes. So I'm going to take you along how these two diseases are two sides of the coin. When we talk about type 1 diabetes, we are talking about insulinopenia. That means there is insulin deficiency, and most of the time this insulinopenia is a result of an autoimmune destruction of the beta cells of Langerhans which are producing the insulin molecule. There are certain evidences which have proven beyond any doubt that yes, there is some form of autoimmune process which is going on, and the evidence which goes in favor is that there are presence of chronic inflammatory mononuclear cells with the residual beta cells in a person who is recently diagnosed as to have insulin-dependent diabetes. The second evidence is that we can have a significantly increased titer of certain antibodies which are related to either insulin or the cells which produce insulin, like islet cell antibodies, islet cell surface antibodies, and insulin autoantibodies could very well be present in the beginning of a person who is developing insulin-dependent diabetes. And finally, we can have an association with other known autoimmune diseases like Addison's disease, Graves' disease, pernicious anemia, and vitiligo. So we do have evidences to prove this point that insulin-dependent diabetes has an immunological basis. In addition to these immunological bases, the other causes of this problem could be viruses, and amongst the viruses are the mumps, rubella, Coxsackie, cytomegalovirus, and Epstein-Barr virus. These viruses may, in one way or the other, can trigger the process of autoimmunity producing diabetes. It also has been seen that children given cow milk in an infancy are more likely to develop diabetes, and it is the BSA, the bovine serum albumin in the cow milk, which is considered to be immunogenic in character. Stress, we already talked about that any form of stress is going to produce an upsurge of counter-regulatory hormones, and one can develop diabetes as a result. Finally, we have some form of genetic predisposition in people who have insulin-dependent diabetes. It's been seen that identical twins of patients with insulin-dependent diabetes have 30 to 35% chance of developing IDDM. Now, this percentage statistics is important for you to keep in mind, because I will be referring to this statistics later on in my talk when we talk about non-insulin dependent diabetes. So we have an identical twin relationship of 30 to 35% in a person who has insulin dependent diabetes. A child of an insulin dependent diabetic parent has an increased chance of developing IDDM if the risk which is there is 1.25 to 2.5% if that child's mother is diabetic, or 2.5 to 5% if the father is insulin dependent diabetic. So we do have some sort of horizontal transmission as well in this statistical data. 90% of insulin dependent diabetic patients have HLA DR3 and or HLA DR4. So there is some sort of genetic influence when we talk about insulin dependent diabetes as well. Now, as well is an important point to be kept in mind. Next one. Talking about non-insulin dependent diabetes, this is by far the commonest type of diabetes that we come across all over the world. Its prevalence is increasing with age, and there is an increase of 10% over age 65. The obesity is going to predispose the person to develop non-insulin dependent diabetes, and these things are now becoming more and more clear when the concept of metabolic syndrome is coming in view. It is the truncal or central obesity which is considered to be more associated with the development of diabetes. Physical activity, again, could it be the result of obesity which a person develops if there is a decrease in the physical activity, or because exercise increases the insulin sensitivity and the person developed some sort of prevention from obesity? One of the two factors may be helpful, or both of them are working on. There is some sort of racial and geographical predisposition to developing diabetes. In a study in the UK, the non-insulin dependent diabetes is 4 times higher in the Asian immigrants to that country as compared to local Caucasian populations of UK origin. Low birth weight has got some relationship with development of diabetes subsequently in life, and also if the mother has a history of gestational diabetes, then the chances of developing diabetes later on subsequently increases, particularly if the person tends to gain weight. That is one of the things that I would like you to keep in mind, because genetic has a very strong relationship with the development of non-insulin dependent diabetes. Although I mentioned that there is a relationship with IDDM, but with NIDDM it has got a more subtle form of relationship. Identical twins of NIDDM have greater than 90% chances. We were talking about 30 to 35% when we were talking about insulin dependent diabetes, and 25% of patients have the first degree relatives as non-insulin dependent diabetics. Now if both parents are diabetic, then this 25% risk can jump to even 40 to 45% chances of their offsprings developing diabetes. Now that is a very interesting statement, and I felt I should write it down here. There are many genes which are considered as potential for developing diabetes, but as yet none of the genes has been isolated except in a disease what we call MODY, that is the abbreviation of maturity onset diabetes of the young. That is one of the conditions where there is a specific gene isolated. Otherwise there hasn't been any gene, a particular gene isolated for development of non-insulin dependent diabetes. Now just to summarize the whole thing, I thought I'll just talk about the clinical features of diabetes. Insulin dependent diabetes usually occurs at a younger age group, that is lesser than 40, whereas non-insulin dependent usually occurs at a higher age group. The duration of insulin dependent diabetes can be marked and measured in days and weeks. That means the duration is of a very short period. On the other hand, when we talk about non-insulin dependent diabetes, we are talking about weeks or months before the symptoms are manifested and appreciated. The symptoms are very classical, very rapid, with polydipsia, polyuria, rapid weight loss, dehydration, and the person can culminate into coma. Non-insulin dependent diabetic, on the other hand, can remain asymptomatic for a very considerable period of time before that person is probably accidentally picked up and found to have diabetes. There could be very, very vague, non-specific symptoms when we talk about non-insulin dependent diabetics. IDDM person is usually a lean built. Non-insulin dependent diabetic person usually is a obese kind of person. Autoantibodies can be seen in IDDM, but you don't see these autoantibodies in a person who has non-insulin dependent diabetes. Ketonuria can occur because it is a very, very rapid development of metabolic problem, whereas when a person has non-insulin dependent diabetes, usually ketones do not appear in the urine. Now that is one of the tests which will indicate that whether a person has an adequate amount of insulin or not. We all know from our knowledge of physiology that insulin is secreted from the pancreas as a pro-molecule, and it is the pro part which is broken down and the rest of the molecule becomes an active molecule. Now this pro-molecule, we call it C-peptides. If the pancreas is not producing optimal amount of insulin, then C-peptide level has to be low. So that is exactly what we see in a patient who has insulin dependent diabetes, that we we have a low or absent C-peptide levels, whereas on the other hand, when we are talking about the non-insulin dependent diabetic patients, we have a normal or a higher amount of C-peptides in the blood. Diabetic complications at presentation may be present in 20% of the individuals at the time of presentation. It is only because of a very insidious form of the development of symptoms in a person who has non-insulin dependent diabetes. The family history of diabetes is more commonly present in an NIDDM patient as compared to the patient who has insulin dependent diabetes. Now that brings me down to another question. Whom should we screen for diabetes? Should we just go up front and screen everybody for diabetes? Would it be cost effective? Would it not be creating a lot of panic in the society? So there are certain guidelines that we have to follow, that whom should we screen for diabetes. One or more parents or sibling with non-insulin dependent diabetes, yes, we should screen that person for diabetes. If somebody has a truncal obesity or central obesity, yes, we should screen that person for diabetes. If there is a previous history of gestational diabetes, yes, we should screen this person for diabetes. If the patient is on potentially diabetogenic drugs, and most common drugs are the diuretics and steroids, yes, we should give that patient a benefit of doubt. Hyperlipidemic patients who are hypertension, and finally, never ever say no to a patient if that patient requests that he or she should be screened for diabetes. So if the patient requests to be screened, we must screen that particular patient. Let me bring this slide once again for my colleague. I promised last time I'm going to bring these things and I'm going to critically analyze, because now I have got enough time to talk about. Now, before I say anything, there are certain things which I would like you to keep in mind. One is that we have different kind of documentations in the medical journals. The first is the research articles. Then the whole collection of research articles take the shape of meta-analysis. Meta-analysis lead to some sort of society giving a recommendation. Finally, there are certain authoritative bodies which give a consensus statements. Now, consensus statements usually come after a few years. Recommendations may come at any time. Original articles and meta-analysis may appear every day. So that is how we have to keep the whole track flowing. There are certain values which I would like you to keep in mind, because these are consensus statements given by the WHO. There are certain recommendations, and yes, sir, I am going to talk about recommendations today. This slide I picked up last time, and I asked the question, who is a diabetic? There were three values which I requested you people to keep in mind: 110, 140 and 200. These are the magic values which the WHO had recommended. And yes, in books you probably today as well see these three values coming up as it is. So if the fasting blood glucose is greater than 140, the person is considered as diabetic. If the random blood glucose is greater than 200, yes, the person is considered as diabetic. And if the values lie between 115 to 139, and if the patient has some sort of symptoms of diabetes, then we give a 75 gram of glucose challenge. The results of the glucose challenge is that if the values at 120 minutes is greater than 140 but is less than 200, we call it that the person has an impaired glucose tolerance. If this value is greater than 200, then we say this patient or this person is diagnosed as to have diabetes. Now this is the consensus statement which was given about 4 to 5 years ago by the World Health Organization. What happened was, since as I said that the original articles, the meta-analysis, they all went on, and there were 2 studies, major studies in the field of diabetes which came in picture. And those were NICE study and UK-PDS studies. Now these 2 studies gave an outline, and those studies gave us references for the assessment of control of diabetes. And they found that there were certain values which, if were exceeded, the chances of complications were higher in those individuals. Then people from different places, different societies, they met and they picked up a few recommendations. And now I'm going to go down and talk to you about recommendations. These were the consensus statements. Now I'm going to go for recommendations. There are 2 major organizations in the field of diabetes. One is IDF, which is International Diabetes Federation, and the other is ADA, which is American Diabetes Association. Those 2 societies are going to respond to these meta-analysis recommendations which have been made in the year 2005 and 2006. Next one. When those recommendations were made, we have now 4 different types of diabetes. Number 1, type 1 diabetes, which we all have agreed upon is insulin-dependent diabetes. Then we have type 2 diabetes, which we all agreed upon, it is non-insulin dependent diabetes. The number 3 category was gestational diabetes, but what came up was that they brought up another new definition, and that definition is called pre-diabetes. Now pre-diabetes is one of the things which you probably will see coming in the literature after the meetings of IDF and after the WHO recommendations, and that is where the whole value started to move. Now it is important that when we are talking about change of values of the diagnostic levels of diabetes, we probably can have a change in the definitions of gestational diabetes, and we will probably have some sort of recommendations on the changes which can occur in a person who is who is undergoing a glucose tolerance test. So I thought, let me just take the definition of few tests that we have. The first one is a fasting blood glucose test. We have to have certain conditions which we call it fasting. The fasting should be at least 8 hours after the last meal. That is what we define as a fasting level for blood glucose. Now this test has become important to diagnose not only diabetes but also pre-diabetes, which I'm going to talk about in my next slide, how we are going to be seeing the fasting blood glucose helping us. Then we have an oral glucose tolerance test, which again now has become a test which will diagnose to us whether the person has diabetes or whether the person has pre-diabetes. And finally, we may have the random blood glucose, which gives us, along with the assessment of symptoms, a test to diagnose diabetes, but it has got no implication when we are talking about the pre-diabetics. The fasting blood glucose, American Diabetes Association recommendations stand that if the blood glucose level is between 100 and 125, this is pre-diabetes. Now this has brought another important question to be discussed. What is the upper level of normal now? we used to take 110 as an upper level of normal. When we start talking about that, when the level is between 100 and 125, that we categorize this particular person as pre-diabetic, then the normal level becomes up to 100. So that is, and again, another question which you probably will be listening about in the next few years, that the upper level of normal has now come down to about 100. And the diagnosis of diabetes starts after we are talking about 100, because 100 to 125 we have started labeling this person as not normal. We call this person as pre-diabetic. Any person who has a fasting blood glucose level of now greater than 126 is considered to be diabetic. Now these are the recommendations of American Diabetes Association. They started this recommendation middle of last year, and they kind of had a joint acceptance early this year. Next one. Next one. Sorry, पिछले वाले ले जाएगा. The other thing which which IDF recommended, again last year in September they recommended this thing, that oral glucose tolerance test should be performed in a person between 100 and 125 milligram per deciliter. Now this is a recommendation. End of this year there is an IDF Congress meeting, and probably a consensus statement may generate by the end of this year about what IDF recommended last year as their recommendation. The random blood glucose level of greater than 100 and less than 200, a person should be given an oral glucose tolerance test. Again, in oral glucose tolerance tests, the value of glucose load has not yet changed. There have been 3 different kinds of glucose loads which have been suggested, but up till now the glucose load in all these recommendations have still been on 75 grams. So the recommendation for glucose tolerance test is that if the 2 hours blood glucose level is between 140 to 199, the person is pre-diabetic. Now that would mean that impaired glucose tolerance, what we used to think about, very soon is going to finish, because that we are categorizing into a person who is pre-diabetic. And if the 2 hours blood glucose level is greater than 200, the person is diagnosed as to have diabetes. So these are the things which still are in a fluid form, but I feel now that I can talk to you, I probably feel more confident in giving these datas and levels to you. So this is in nutshell. 99 and below is normal, 100 to 125 is pre-diabetic, and 126 and above, the person is said to be diabetic. This we are talking about a person's fasting blood glucose. Now let's talk about what is a pre-diabetes. Certainly we have talked for the last few minutes about pre-diabetes. What is a pre-diabetes? Blood glucose levels are higher than normal, but not high enough to be categorized as diabetic. This is the definition of pre-diabetic. Many people with pre-diabetes develop type 2 diabetes within next 10 years. So the person is predisposed of developing diabetes in a short-term basis. Pre-diabetics also have an increased risk of heart disease and stroke. And finally, with modest weight loss and moderate physical exercises, people with pre-diabetics can actually postpone the development or prevent the development of type 2 diabetes in these people. So graphically, up to 100 we are normal. Between 100 to 126 we are talking about pre-diabetes, and above 126, when we talk about fasting plasma glucose, we call call the person as a diabetic. And with oral glucose tolerance test, up to, if it's less than 140 milligrams, we call it normal. If it ranges between 140 to less than 200, we call it pre-diabetic. And if it is above a 200 level, we categorize these particular glucose tolerance tests as diabetics. Then we talk about how we are going to assess our control of diabetes, and as I mentioned last time, I actually have brought in my previous slides and joined these slides together just to make a complete overview. I talked about urine testing. It is not a very reliable method of assessing the diabetic control because glycosuria occurs if the glucose level exceeds the renal threshold of 180 milligrams. It is an unreliable method of testing the control of sugar. We are giving a very big leverage for the blood sugar profile to be fluctuating in these limits. Negative test cannot distinguish the blood sugar level because when we are when the urine goes into the bladder, it is a representative of blood sugar at that point in time. Blood glucose, the fasting glucose, is a good test for non-insulin dependent diabetics. Since we have insulin dependent diabetics, the values are very fluctuant, so it has to be done for insulin dependent diabetics more frequently. The values which we should be keeping in mind and recommending to our patients should be pre-meals 72 to 126 milligrams, and 3 hours after meal it should not exceed 160 milligrams. Glycosylated hemoglobin, it indicates a control over 3 months period, and the range that we should keep our patients within should be between 6.5 to 7%. Most of the people do not use serum fructosamine nowadays. It has got the same kind of implication as what we are talking about glycosylated hemoglobin, but it only represents a short-term control rather than the glycosylated hemoglobin, which gives a long-term 3-monthly control. Now, these machines have actually been a very big blessing for a person who has diabetes. These are the home glucose monitoring devices. They have changed the perception of the control of diabetes. This definitely has changed the direction of management. But what is important is that we should be telling our patients how much and how many times they should be controlling and checking their blood glucose. For a non-insulin dependent diabetic, fasting and 2 hours blood glucose is probably what is important. For a person who has insulin dependent diabetes, 3 times probably is one which needs to be kept in mind. And for a person, next one, for a person who is pregnant or has a gestational diabetes, that 3 values actually automatically changes into 6 values, both pre and post meals. Now, the tests that we are recommending are very, very individualized. Different goals may be required for specific individuals, like pregnants, very old people, very young people, and those people who have serious underlying medical conditions. They should be given a different sort of importance as far as the control is concerned. Patients who are tightly controlling glucose level need to take 4 or more readings a day. Blood glucose level generally are more stable in type 2 diabetics as compared to type 1. So the expert recommendations is that you may use and check your blood sugar once or twice a day. The levels that we recommend should be between 80 to 140 as pre-meal values, and a bedtime value of 100 to 160 milligrams. Glycosylated hemoglobin, which indicates the control of blood glucose, is not a test to be utilized as an initial diagnostic test. It is not the test that has got a bearing on the diagnosis of diabetes, but it can tell us the severity of this disease. It is not affected by the food, so it can be taken up anytime during the day or night. A home test has also been given, but it has not yet come very openly in the market. The range that we would want a diabetic person to be is below 7%, and if the value is around 11 to 12%, it indicates that the control is extremely poor and the person is going to get into complications related to diabetes. With this, I'll stop here, and hopefully, inshallah, next Wednesday, I'm going to start about talking how we are going to manage the patient who has diabetes, both type 1 and type 2. Thank you very much.